Welcome to my comprehensive examination. I am Alexandria Zayer. I'm a registered nurse with my BSN. This is for the Midwifery Master's Program at University of Colorado, and I will be presenting today on a midwife's role within a perinatal palliative care team. I want to start by naming that I intend for this presentation to be inclusive to all genders and individuals. In order to be consistent with the research I am drawing upon, I will maintain a congruence with those sources. However, I invite anybody to adapt the pronouns that best fit each person. In 2013, English and Hessler published a literature review and ethical guideline for doing prenatal palliative care consultations. It included advanced care birth planning to parents who chose to continue a pregnancy after receiving a fetal terminal diagnosis. This article presented the following case study for me to draw upon. A couple in 2009 received a call from a perinatologist informing them that their unborn baby had trisomy 18. Trisomy 18 is a terminal diagnosis, meaning that it is not compatible with life. The perinatologist told the couple that termination was recommended and as soon as possible, since the fetus was already 18 gestational weeks old. This couple was devastated. No other options were discussed or provided. They spent their time seeking out other healthcare providers who could give them more direction and a quote for a sense of peace. As you can see from what is displayed on this slide, they felt very alone to make an impossible decision. Before I move into this next slide, I want to share a little bit more about my personal experience. I've spent most of my nursing career in palliative and hospice nursing. Part of the populations that I have worked with is pediatrics, and that includes neonates and infants. When I worked with these individuals, oftentimes I would start by admitting them from the hospital onto our services. When I did this, I noticed that it always felt as if our services came on very late and showed me that that myth about what palliative and hospice is continues to exist in our culture, society, and even amongst the medical field, that it is really this last minute resort of an option when no other options are left within the medical field. When I would care for these families within their home settings, I really noticed that the mothers were having clinical symptoms of anxiety and depression. And I really wondered if our services came on earlier and was without them throughout the antepartum and intrapartum period, how this might have changed that outcome. Furthermore, when I wasn't working as a hospice nurse, I also spent my time as a doula, serving pregnant women in birth and throughout pregnancy. If you spend enough time in this area of service, you eventually realize there's a place where death and end of life care touches pregnancy and birth. So eventually, I was called to serve women at the bedside with stillbirths. When I would attend these births, I also noticed that it felt like healthcare providers didn't exactly know what to say and oftentimes lacked in services. So I felt that these women and their families were walking away from a very traumatizing situation, and they were left with little resources, including bereavement services and follow-up care. And coming from my personal experience of palliative and hospice, where bereavement services is integrated into that framework, I just felt very confused and wondering why that wasn't a part of these situations as well. So, even though as a healthcare provider, I was seeing what was a major gap in care, I had actually never spent the time to do a literature review or look up the statistics. So, when I did, this is what I found. Almost half of all hospital deaths are neonates, and only 2% of that population is receiving palliative care services. One in 160 births result in a stillbirth. And aneuploidy, as we saw in our case study, accounts for more than 50% of first trimester miscarriages, 20% of second trimester losses, and 6 to 8% of stillbirths and early childhood deaths. The Colorado Department of Public Health and Environment just released this year their maternal death rate from 2014 to 2016. It reported that 1 in 4 maternal deaths were related to mental health conditions. Furthermore, per the CDPHE report, there was no difference in maternal death rate as it related to race and or ethnicity here in Colorado, which I feel is an important demographic to highlight when some states are experiencing a rate of Black mothers dying 5 to 12 times the rate compared to Caucasian mothers. And perinatal depression affects 1 in 7 women. So as I looked at these numbers, I just started to wonder more about how I could help and what the solutions were. And I really started wondering how midwifery care could potentially be part of the solution. Before we talk about midwifery care as part of the solution, I feel it's really important to discuss the history of midwifery care. Martha Ballard, who is displayed on our screen, was a colonial midwife in the 18th century. She serves as an excellent example of what the midwife role once was. Van Hoover and Holt report that from her diary entries in a 3-week period, she attended 4 births, responded to 1 false labor, made 16 medical calls that included dispensing of medication, harvested and prepared medicinal herbs, and also prepared 3 bodies for burial. Furthermore, they report in their article on midwifing the end of life, expanding the scope of modern midwifery practice to reclaim palliative care, that historically midwives were practitioners whose roles in society were cradle to grave. So, what happened that midwives today are still not responsible for these roles within society? In the 19th century, the United States started to professionalize medicine, meaning that individual states started passing laws where only physicians that were licensed could practice medicine. Unlike other countries that incorporated midwives into this concept of professionalism, the United States did not. So we almost completely lost midwifery care within the United States. It wasn't until the 20th century that the American College of Nurse Midwives was established and created what we know as modern midwifery today. So, when I was thinking back to the case study and the words that that woman shared, that she felt alone to make an impossible decision, I really started to feel and think into how shared decision making wasn't a part of this case at all. The American College of Nurse Midwives has a position statement on shared decision making because it is a core value to midwives. They report that shared decision making is a partnership in which the woman and providers share information and values to make the best decisions regarding a plan of care. And this to me is what really starts to point us into how I started to really think about midwifery as a part of the solution. Van Hoover and Halt report that midwives are well equipped to serve as hospice and palliative care clinicians. And I believe that bridging palliative and midwifery care would be a seamless act and an obvious solution to a gap in women's healthcare today. When looking at theory, I felt it was really important to compare midwifery and palliative care frameworks. Van Hoover and Holt 2016 did an excellent job in making this comparison. So we will be looking across the slide at each bullet point when we're comparing the frameworks. So first off, both midwifery and palliative care talk about normal physiological processes. Midwifery recognizes that pregnancy and birth is a normal physiological developmental process, while the palliative framework recognizes that end of life and dying is also a normal physiological and developmental process. The next bullet point down, both frameworks also talk about technology, which technology is a huge part of what makes modern medicine today. And they both understand that there is a time and a place for technology, but there's also a fine line where technology crosses over and creates more suffering. So the midwifery framework likes to hold it that technology can come into play once the normal process has been allowed first and complications start to actually arise. While palliative care holds that technology actually could be an option for relieving suffering rather than causing suffering. And then the last bullet point that I love about both of these frameworks is not only do they really have a centered care approach of that person that they're taking care of, but they realize that they're also having a ripple effect out into the whole family unit. And they strive to hold the whole family unit, with midwifery care centering around that woman and their family, and palliative care centering around that dying person and their family unit with a holistic approach. Both frameworks strive to keep the control in the patient's hand. Providers from both frameworks are advocates for the right to self-determination, informed choice, and shared decision-making. Both practices work with vulnerable populations, so they understand the importance of continuity of care, with midwifery holding that pregnant person as a vulnerable time, and palliative care holding that person who is dying, which is also a very vulnerable time. Both practices understand that there is a therapeutic value in human presence, giving skillful guidance, counseling, communication to facilitate healthy families and interpersonal relationships. For all these bridged similarities is why I feel there is a desperate need for integrating midwives back into the roles of end-of-life healthcare providers. So with all that was shared and my personal experience, I really wanted to put this all to the test. And this is the PICO question that I developed. Mothers, partners who receive a life-limiting fetal diagnosis and continue the pregnancy through birth, who prepare an advanced care directive birth plan with palliative care team guidance versus those who do not have an advanced care birth plan and palliative care guidance have decreased rates of depression, anxiety, and PTSD. So I really wanted to see if by having palliative care and an advanced care birth plan involved with this population, if it would decrease what I was seeing as mental health outcome concerns. Before we dive into the literature review, I feel it's really important to unpack the pathophysiology of that outcome within the PICO question. First, I want to name that depression and anxiety has a twofold risk within women. So this is important to understand because, as mentioned, that it is a vulnerable population that we already are working with. When we look at major depressive disorder, it's important to understand that there are biological factors that play into this disorder, and that means genetics. So another thing to consider when we are meeting and consulting with women and patients at that first consultation, we really don't know if they potentially already have a genetic disposition to make them more vulnerable to these health outcomes, mental health outcomes. So we could already be working with a vulnerable population. Also, when you look into the pathophysiology, they discuss how environmental factors or environmental stressors play a significant role with tipping someone into a diagnosis. And that is defined by any huge life change. So we all know that having a baby is a huge life change. And we can already see that that could tip someone into postpartum depression. And clearly, as we are presenting here in this case study, that death is considered a major environmental stressor and factor. And so that this also really tips someone, if they're already vulnerable, to having this diagnosis. I want to state one thing about clinical symptoms of depression that I want to really just highlight right now while we're in the pathophysiology, because it's going to come up in our literature review. And that is that these persons can present with feelings of powerlessness and excessive guilt. So we'll just hold that there and we'll rediscuss it in the literature review. A dominant theory for depression is that there is decreased monoamine neurotransmission. So that includes serotonin, norepinephrine, and or dopamine. Now, there are a lot of bodies of research and different theories and understandings that are being unpacked so that we can further understand the pathophysiology of major depressive disorder. However, I decided that I really wanted to narrow down into these next 2 points because it's going to relate into the next slide and a bigger point that I'm trying to make here today. So there is a beautiful axis that exists within the human body, and it is called the hypothalamic pituitary adrenal, or HPA axis. It plays an important role in how we cope with stress. So when an individual experiences acute stress, it releases the hormones that are needed to handle the situation at hand. However, researchers started to discover that there was increased levels of glucocorticoids in people with depression, which makes a lot of sense. If one is chronically stressed, the HPA axis never gets to engage their negative feedback loop. So that leaves the body in a chronic state of inflammation, which again, the inflammatory response is a beautiful built-in mechanism to protect us. But like any system that is overused, it develops its problems. People with depression were noted to have higher levels of cytokines in the body. And increased levels of cytokines from that inflammatory response have been shown to decrease neurogenesis, causing neuronal damage. It's shown to have atrophy of brain structures, including the frontal lobe and limbic system, and loss of those synapses between the neurotransmissions. So, to understand generalized anxiety disorder, we first need to understand the limbic system within the brain. When we look at the screen here, we can see the four structures that make up the limbic system. That's the hippocampus, the amygdala, the thalamus, and the hypothalamus. The amygdala is a significant part of this limbic system. It is also known as the fear center, and it is necessary in detecting potential threats. The amygdala works within a circuit with the prefrontal cortex, and that's this area of the brain right here. I'm going to call it PFC for short. So PFC functions to exert an inhibitory influence on the amygdala activation. This allows fear extinction to occur and helps us with our decision making by processing emotional information from the amygdala. Again, this is such an important function in the body. Lessening amygdala activation enables us as individuals to acquire coping skills in life. However, someone with anxiety has increased activation in the amygdala with a deficit in the PFC. So it leads to that dysfunction of emotional processing of fear and decision making about that fear. Also, we see that they have found decreased serotonin levels with people who have anxiety, and same as the major depressive disorder, that genetics and environmental factors do play a role in this diagnosis. PTSD pathophysiology is similar to anxiety. It once was part of many different types of anxiety disorders, but the DSM 5 recently moved it into its own diagnosis category related to the difference in the clinical presentation. With a dysfunction in the emotional fear memory system of that limbic system we just talked about, leading to spontaneous recollection of the traumatic event with recurrent nightmares, flashbacks, or other chronic psychological distress. I want to point out that all three disorders relate back to environmental factors of stress, with activating the built-in stress responses with the body, including that inflammatory system. And I want to just point you down to the next part of this slide with stress, the inflammatory system, and chronic disease, because I really want to point out how those all these disorders, these mental health outcomes really lead us to this point. Allostasis is a term that's used in stress research. It is the changing set point within the body that allows adaptation to stress versus a single set point that you return to, like homeostasis. Allostatic load is what's considered the wear and tear on one's body from chronic stress exposure. And when one experiences stress within the body, it has an indirect impact on the central and peripheral nervous systems. So, once again, there is a beautiful system within the body for dealing with acute stress. And acute stress is actually considered to be immune protective versus when you flip into chronic stress, it is immune suppressive. So someone who experiences what's called allostatic overload, the parasympathetic nervous system cannot restrain the sympathetic nervous system. The parasympathetic nervous system is responsible for the anti-inflammatory effects within the body. And this is significant pathophysiology to understand because prolonged inflammatory responses in the body are now linked to chronic diseases. So that includes cardiovascular, hypertension, diabetes, and cancer. Midwives are also primary health care providers. Our scope of practice is to provide care for women throughout their lifespan. So, how does potentially underdiagnosing and treating mental health outcomes then impact the woman's medical health into the future with diagnoses of chronic diseases? Furthermore, if we look beyond just recognizing, diagnosing, treating mental health disorders, but that we are practicing preventative medicine as providers and protecting our patients' medical health outcomes into the future. So let's begin the literature review. So I knew that I signed myself up for a very big literature review. There were a lot of angles that I was coming at to try to get to unpacking this PICO question and getting to some solutions. So I had to really start by thinking about what my big concepts were going to be for searching PubMed. And PubMed is the database that I chose to use. And I researched the last 5 years, 2015 to 2020. I started by breaking down into a lot of these concepts that you've been hearing in our presentation today so far. So starting with perinatal, and that was anything from looking into infant, fetus, and stillbirth. Palliative care, and looking at it from a nursing approach, hospice, that bereavement piece, and of course, midwifery with everything from traditional birth attendant to midwife. And then with mental health, I went from broad to every diagnosis that I wanted to look into as depression, anxiety, and PTSD. You'll know I highlighted the ones in red as the ones that really started to lead me down the path of the articles I was really looking at and for. I want to name a few more things here. When I was doing this literature review, there were times that I felt that there's barely anything to choose from. There's so much more research that's needed. And often I would find that in the articles that I read, that more research is needed. And other times I was blown away with what I was finding. And there was a lot of articles by other professionals within the medical field who also felt that this was a gap in care. A lot of articles around guidelines and how to start programs. And then I also found a lot of qualitative research. And I personally am a big fan of qualitative research. I believe that the medical field is a market that is actually driven and needs to be driven more by consumer demand. And I believe qualitative research really points us into what the consumers of the medical field have to say and how it can redirect our practices, our care, and our policies. But for this particular presentation, I really wanted to boil down to that quantitative research for my PICO question. So this is what I found. These were the 3 articles I boiled down my literature review to. Starting with the first one, when we look at the stillbirth mesh term depression, brought me to 13 results, and I chose the article Depression Post-Traumatic Stress Symptoms After a Perinatal Loss in a Population-Based Sample 2016. I chose this article because I feel that it really unpacked that piece that I wanted to look at, where, as an environmental factor, stress factor of perinatal loss and how it affected mental health. The second article is a depression mesh term, mother's mesh term, and perinatal death, and that brought me to two results. But luckily, this article, the impact of decision quality on mental health following a periviable delivery, was in there 2019. And I feel that this article really spoke specifically to that point on how decision quality for individuals really does impact their future, their mental health outcomes. And for me, felt like it was really going to address that piece around shared decision making being so important. And then my third article, mesh terms of randomized control trial, palliative care, and infant, 7 results. And I chose the article, A Randomized Trial of Early Palliative Care for Maternal Stress in Infants Prenatally Diagnosed with Single Ventricle Heart Disease, 2018. And I chose this article because it really brought me back to that question I had around, if palliative care services came in early, how it affected mental health outcomes. So let's look at each article individually. So the first article, Gold et al. 2016, Depression and Post-Traumatic Stress Symptoms After Perinatal Loss in a Population-Based Sample. This study was in collaboration with the Michigan Department of Community Health. It was to conduct a longitudinal survey of bereaved mothers with stillbirth or neonate death under 28 days of life, compared to a control group of non-bereaved mothers who had live births. The survey took place 9 months after the loss and over a 2-year period to measure symptoms of depression. The study used the Patient Health Questionnaire 8 and the civilian version of the PTSD checklist, with a score of 35 or higher being identified as a positive screen for PTSD. So let's look into the column of the results, which I am showing the bereaved, and they are adjusted odds ratios. So it's that comparison to the non-bereaved control group. Bereaved had a 4-fold higher odds of having a positive screen for depression and a 7-fold higher odds of a positive screen for post-traumatic stress disorder compared to the non-bereaved. So those are significant p-values. There was some racial demographics that were noted. First, there was no significant difference among women of different races when it came to depression and/or PTSD. However, bereaved African American women with positive screens for either the depression or the PTSD were significantly less likely to be receiving any type of psychiatric treatment compared to Caucasian women. This finding was concerning, related to African Americans face twice the rate of stillbirth and early infant death compared to Caucasians. And then looking at the limitations and strengths. The limitations were that screening tools were used to identify psychiatric symptoms rather than the gold standard of clinical interviews. And mental health screens have the potential to either over or under identify women with clinical disorders. And the strength of the study really was that that non-bereaved group, that control group, was randomized. And that put it at a level 2 of evidence per ACOG. Our second study, Tucker Edmonds et al. 2019, The Impact of Decision Quality on Mental Health Following a Periviable Delivery. This was another longitudinal study that took place at 3 months following a periviable birth. The cohort consisted of pregnant women between 22 and 24 weeks gestation who presented with a pregnancy complication with a need or a threat of periviable delivery. The cohort consisted of both those who were bereaved and those with surviving children. And this took place at two academic hospitals. First, I want to look at the population a little bit more. So, when we look at pregnant women and the important other, in this study, the pregnant woman was supposed to identify someone as an important other. So, this could be anything from the father of the baby, a significant other, to some women did not have partners or an important other to identify, and they were not eliminated from the study because of this. And then also, some of them identified other friends and family as that important other that was with them in this process. And if you look at that difference in population, the 30 and the 16, this is actually something that you'll see a lot when you do a literature review on these subjects, is that there is this common idea and awareness that there does need to be more research on how this is impacting those important others, whether it was the parent of the baby, the father of the baby, the significant other, just that whole family unit. So I just wanted to name that now. So moving into the results, I want to talk about how these results were collected. They used tools to screen, and it was with the PHQ-9 for depression and the GAD-7 for anxiety. PTSD was used with the impact of events scale that was revised, so the IESR 22. And for decision quality, that was measured in terms of conflict, control, regret, and satisfaction with the decision. When we look at our first result, the lower decisional control, we see that when that was lower, depression went up, anxiety went up. And when we look at higher decisional regret, that was higher, then depression was higher. And I wanted to just link this back to that clinical presentation of depression that I mentioned in the pathophysiology slide, that we usually see powerlessness and excessive guilt with depression. And I feel that these p-values point exactly to that outcome. When looking at the PTSD scoring, I want to name a little bit about the scores. So if you receive a 24 or higher, it's associated with PTSD. If scores are 37 or higher, it indicates that PTSD can be high enough to suppress the immune system. So once again, back to that pathophysiology. First, let's look at the important other. So these are average scores. The average score for the important other was 36.5. That is 0.5 away from that 37 that puts a person not only with a diagnosis of PTSD, but that they are having immune suppressive, that inflammatory response within the body that puts them at higher risk for developing other diseases. So also, since this is an average score, clearly there were people who scored high enough to tip over into both of those. And then when we look at the average score of the pregnant women, 43.9, that is clearly high enough to where they not only had the PTSD diagnosis, but that they were also immunocompromised, immunosuppressed, and at higher risk for developing other health concerns. So let's look at the limitations. First of all, small samples, 30 and 16, and as we discussed with this, the important other population being even smaller. And it was a short interval of 3-month follow-up. So there's a question if this was really appropriate time for assessing these mental health outcomes related to potentially still being in a grief and bereavement period. However, I feel that there are a lot of strengths in this study, that the results really point to how this can change practice and policy, with a need for quality antenatal counseling, communication, and parental decision, leading to increased well-being of parents following a periviable birth. And this study was a level 2 of evidence per ACOG. And our last study, Hancock et al. 2018, a randomized trial of early palliative care and a randomized trial of early palliative care for maternal stress in infants prenatally diagnosed with single ventricle heart disease. Participants were recruited from 2013 to 2015. They were referred to the University of Michigan's Children's Hospital Congenital Heart Center. Mothers were pregnant with fetuses with single ventricle heart disease, and they planned to undergo the first stage of that surgery during the neonatal period. The mothers were randomized to either receive the early palliative care consultation as the intervention group of this study, or they were getting institutional standard care, which did include either no or late perinatal palliative care as the control group. There were 4 instruments used to survey and measure these results and outcomes. The first was the Beck Depression Inventory 2. Second was State Trait Anxiety Index. Third was Brief Cope Inventory, and the PEDQL Family Impact Module. These screening tools were used to collect baseline scores in the prenatal period and again postnatally. So when we look at the results, it is the scoring for the intervention group, the early palliative care. And just remember that these results were from both periods, prenatally and postpartum. So they found that there was decreased anxiety when the group received the palliative care intervention. And then we see that when we look at the brief cope inventory scoring and the family impact module, that there was increased rates of positive framing and communication and family relationship scoring compared to that standard care. And I think these last results are really important because it points back to that midwifery and palliative care framework that really looks at how do we care for the whole family unit? How do we center around this person and have a ripple effect out into that family? And I feel that these results clearly show that when palliative care is involved early, that not only are we decreasing the anxiety of that family, but we are seeing a better outcome for that whole family unit. So let's look at strengths and limitations. So the limitations were that this study did happen in a single care center and with a narrow population of the single ventricle heart disease. So it would be very interesting to see if this study was recreated across more care centers nationwide, and if they widen the scope of the population to other diseases, as we saw in our case study with the aneuploidy, if we would get similar results. I also want to name that there was a lack of diversity of demographics. Part of the requirements were participants had to be English speaking, which may have accounted for their lack of diversity. Furthermore, I thought that this was an important limitation to name, as we addressed in the first study, when some races seem to be more at the effect of poor neonate outcomes. And also, this study did use screening tools versus that gold standard of the clinical diagnosing. And the strength of this was really that it was the highest level of evidence, level 1 per ACOG, with being an RCT. One other point I want to note from this study is the study and the conclusion really named that they did this intervention at the time of birth, and they recognize that there is a need to do this in prenatal care, and that they want to study and look at that further into the future. And I thought that was really important, because that is a place that this could be a major improvement, that it's not just at the time of birth, but how do we walk with someone through the antepartum period as well. So the American College of Obstetricians and Gynecologists released a committee opinion last year, 2019, for perinatal palliative care. And looking at that first bullet point, women should have control over decisions that affect their bodies. And I just feel that this points perfectly back to those frameworks of midwifery and palliative care, that they advocate for the right to self-determination, informed choice, and shared decision-making. Looking at the second bullet point, perinatal palliative comfort care is one of several options along a spectrum of care. So we're not denying a woman's right to choose pregnancy termination and or full neonatal resuscitation and treatment. The important part that's getting addressed within this opinion is that it's about all options are being given, as we have seen in the case study, where a lot of times it is not. And that information has to be given in a sufficient amount, so true informed decision making can be made. The third bullet point, support and care should be provided during the prenatal, birth, postnatal, and bereavement periods. And I feel like this speaks to the role of the midwife. We provide care in all of those periods. The one piece that starts to really point us to the next slide that we'll talk about is the bereavement period, which would get integrated into the postpartum period. However, I don't feel that this is a gap that midwives are completely unfamiliar with. We definitely take care of women in the postpartum period who have experienced miscarriage and stillbirth, or when midwives are taking histories, oftentimes we do discover that this is something that that patient has gone through, and it comes up in our initial consultations. So it's not completely unfamiliar. And then the last bullet point, which I just love this so much, the birth plan is an individualized proposal for delivery and neonatal care and is a critical prenatal component of the perinatal palliative comfort care. And I just love that their committee opinion addresses exactly the intervention that we are looking at within the PICO question about creating an individualized birth plan. And we will move on to the next slide to look at the American College of Nurse Midwives position statement, which is called the Expansion of Midwifery Practice and Skills Beyond Basic Core Competencies. And I feel that this position statement really is that first step in implementing this into the practice of midwives. Before we talk about this, though, I want to talk about one more study. Martinez Sereno et al. 2018 interviewed 18 midwives across 11 different hospitals and care centers to better understand the midwife's experiences with taking care of fetal deaths after 28 weeks. And I really believe this study gives us a glance into how we will need to start the beginning steps of implementing palliative care and the advanced care birth plan into midwifery care by looking at the common qualitative themes that were discovered within the research, which really can start to point us into those gaps, so we can really address those within the implementation process. So, first of all, there was a theme that healthcare professionals are for life and not death. With midwifery and midwives having a difficult time in what ended up in a death outcome. So I feel like this really points back to, and it was also spoken about in the article, that some of the midwives' feelings that came up around this is because it was also part of that reflection that we see from our cultural society norms, where there continues to be death as a taboo subject, and that midwives also struggled with that there was a lack of knowledge that there could even be a death outcome in the antepartum and birth time. And I feel that this is really important to highlight because this is going to be a hard piece to tackle. And we have to tackle it within ourselves as midwives and also start changing and educating the culture around this so we can see these better outcomes with deeper understanding. And I think this also pointed back into how we see it again in society where there's kind of this lack of awareness or respect for death of a child at 36 weeks as a death of a child at 15 years of age. And because we continue to have this taboo, there was this lack of knowledge of how midwives felt that they could show up and have understanding and resources for that mourning process that parents were in. Also, midwives named that they also felt like they were in a grieving process and they were mourning and they weren't receiving the support they needed to move through that process. And that furthermore, there was not debriefings happening within these organizations. So that meant that there was no reviewing of the experiences that they were having with these cases. So no talking about the strengths and no talking about the weaknesses where there could be improvement for the next case. Also, when you look at the literature review of these subjects, one of the common qualitative points that get made a lot by parents who have gone through this process is that if they received bad attitudes by the staff, or even just what was this kind of emotional, energetic separation from the parents and the experience that was going on, that that was very harmful to their process. And in this article, they talk about that compassionate midwifery could be a solution to this. And I think that makes so much sense when we think back to the framework of midwifery, with a core value being of how to hold human presence. Also, the midwives named that they felt like there were guidelines that existed out there, but they were not integrated within the healthcare environment. So they often felt that their organizations were not prepared for this event. And I feel that we can easily address that one. So some conclusions and recommendations in this article that will point us back into this position statement. They felt that grief training and communication skills needed to be a required part of the learning of the midwife, and something that we see in continued education was really strongly encouraged. They also pointed out that oftentimes the midwife was present for the birth itself, but they were not part of the prenatal care. So that midwives really, they have competence. They're recognized as a part of their professional role. So they really do need to be integrated into being part of the care providers in the prenatal antepartum period and not just the birth outcome. They also reported that there needed to be adequate support and follow-up care. And this also gets backed both by ACOG and the CDPHE. They both have recommendations on increasing access and frequency of postpartum care visits to improve maternal health outcomes. And furthermore, that a midwife should continue to be one of the referenced healthcare professionals in this postpartum time. And other countries where this is practiced, they are known as the bereavement midwife. So again, that the midwife gets to see them in those postpartum periods and follow up and bereavement pieces. So looking to the American College Nurse Midwives position statement, they state that as knowledge expands and technology advances, the expansion of scope of practice will become increasingly necessary and or desirable for the CNM. And when we look at these two bullet points, what I like about these bullets is they talk about when caring for women and their families, midwives may identify the need to offer expanded services and acquire further education to provide optimal care. So I feel that really points us back to the implementation piece, that further education might be needed, and they're recognizing to give that optimal care, we really need to be able to have the opportunity to expand the services that midwives provide. And then the last piece here, the implementation of a new procedure should be based on consumer demand, standards for safe practice, and the availability of other qualified personnel. So the other qualified personnel is that palliative care medicine framework that is going to help hold midwives stepping into this role. And once again, that consumer demand. And when you look at the qualitative research, when you do this literature review, it's so clear that this is wanted by consumers. So I really feel like this position statement really sets us up nicely for that first step of really implementing this into practice. Um, that we're going to have to start with education and looking at that specific skill set of the advanced care birth plan. So let's jump into that. So English and Hessler 2013 created this document you see on the screen. It is a birth plan, which midwives are not unfamiliar with. It's a big part of their role. They create birth plans with the clients that they work with. And the piece that would need to get implemented into really understanding this particular birth plan is that advanced care piece. So they drew from a 4-topic method, Johnson et al. 2002, and we're going to review each of those 4 quadrants to better understand how you create an advanced care birth plan. The first section is the medical indications. So this is like any other medical history that a midwife would take. Same things you want to know in there. Any potential health concerns, diagnoses, just the traditional medical history. So there's no changes there. Moving over to the second quadrant, the parent preferences. This is the piece that further education is going to be needed. Ideally, this just starts getting integrated within the midwife's basic education that they're already receiving, or it could also be that clearly would also be needed for midwives that already exist, additional education once they are licensed. And that's the those palliative pieces that haven't been learned yet, that need to be understood, and the support that we receive by our palliative medicine frameworks to better understand and know what options to offer families. So that could be anything from that the parents do not want the baby to be transferred to the NICU. They do not want resuscitation attempted. It could be that they want promotion of as much quiet skin to skin time, breastfeeding, and other palliative comfort measures that we provide, like allowing some oxygen that may provide more comfort as that baby passes. Next, we move to the quality of life. And this piece I think is really important because it kind of outlines about everyone involved. So the parents knowing a little bit more individually about them, and other family members or important others. Another important piece I think that needs to go into this piece is there might be other siblings involved. So are the parents sharing with the sibling? Do they want the sibling involved? How is the sibling doing in this information? And the last quadrant, the contextual issues. And I think that this is a very important piece because it points us back to those environmental factors and stressors that we talked about in the pathophysiology. So we already know that we're working with a environmental factor and stressor of a death outcome that can tip that family, these individuals, into those mental health concerns. But are there other stressors? Are there other factors that could put them at higher risk? So are they having financial concerns? Is there lack of social support? And then just other things that are really important to know, especially when it comes to death and dying, is their religious or cultural values and influences that need to be addressed at those times, and how the family unit views things. And then the last two pieces is the discussion. So this is just a health provider summary of care. So ideally, there will be the initial consultation where we start this birth plan and multiple visits to continue to see this family through the antepartum period leading up to the birth. And how did things unfold through time right before that? This is kind of that final document of the birth plan. And then the last piece, that plan and action. So this is a living document. This goes within the person's healthcare medical record, whether that's electronically or it is within their file, on their chart, in the room. That way, every individual healthcare provider who is involved within this case knows what's going to happen. And this part can include anything from the family wanting to make sure photographs are taken, or that they get hand and footprints of that baby. And it could also mean that sometimes the baby may not die as expected in those first few moments, hours, or days, and the baby is going to go home with the family. So do we then need to get hospice involved, and who are we calling? And I just feel that this birth plan really points us back to a lot of that clinical symptoms that we see with depression, and what the research showed us in the results about a birth plan gives a person a sense of feeling that they have increased control, decisional control. And I feel that that really is that core value of midwifery and the palliative framework, is to put the control back into the hands of that person we're centering around in their family unit. And so I really feel that this is an intervention and a skill set when midwives learn that we are going to be um, hopefully decreasing those sense of powerlessness or maybe excessive guilt over the decision they made, because high quality decision went into meeting with healthcare professionals, really unpacking the values and getting to how they want this process to look. So, increasing that sense of power and control and feeling good around the decisions that they're making for their fetal terminal diagnosis that they've received. There was a cross-sectional study by Wool et al. 2018 that reported that 97.5% of participants that did continue their pregnancy did not have regrets. So we can see by that number that there was not having that high decisional regret and feeling really good about the decision they made. And I want to end on a story of a woman who did receive a fetal terminal diagnosis. And as we saw in our original case study that led us here, they also received the recommendation of termination with no other decisions or options discussed. So that woman did move forward with making an appointment for the termination. However, she ended up going into spontaneous labor prior to that appointment. So she went to the hospital where she did give birth to her baby and got to spend a few moments meeting that baby and holding that baby before they passed. The healthcare provider that was with that woman said, "I'm so glad you got to meet your baby and say goodbye." And that woman said, "I can't believe I almost didn't do this." So I believe it's important that healthcare providers look at their biases, even when they think that they are offering the best option at hand. We really don't know what is going to serve an individual and how meaningful providing opportunities for good goodbyes can affect mental health outcomes. These are my references. And thank you for listening to my presentation on a midwife's role within a perinatal palliative care team.